I know my asthma. I've had it all my life. I don't need to be treated like a child. If it's bad, I take my inhaler. If it's worse, I go to the hospital. It's as easy as that.
We're just so busy. All our appointments are gone half an hour after we've opened. It's impossible to please everyone.
I'm worried that Kevin's mum doesn't really understand how quickly his asthma can deteriorate, especially in the hay fever season. She says he always uses his steroid inhaler, but I know she doesn't order enough prescriptions for that to be true.
ARRISA UK. At-risk registers integrated into primary care to stop asthma crises in the UK. Module 1. Recognising asthma risk. This module will start with leaders in the field describing the importance of and background to the ARRISA approach. It will then be divided in 4 sections that will contain a case scenario of a typical at-risk patient. This is followed by details of the ARRISA system, and then we will revisit the case scenario showing how it can work. Finally, we will discuss how the ARRISA approach can be integrated in your practice. After each section, we ask that you complete the self-reflection components. The self-reflection is devised to help you think about the challenges you face in your practice and will help you fully consider the module content. This information will also be useful to the ARRISA team to ensure that practices have all the support they need. It will not test your knowledge on asthma, and there are no right or wrong answers. For this reason, there will not be any feedback or model answers, as in e-learnings you may have done in the past. Please be assured that your responses will be accessible only to the research team, and that no report or publication using these responses will contain personal or practice identifiable information. Let's hear from leaders in the field.
As a patient-focused organisation, we know only too well just how frightening and devastating an asthma attack can be. And they can be more than frightening, they can be fatal. 3 people every day in the UK die of an asthma attack, and the sad truth is that a good proportion of those could be prevented. The UK has some of the highest rates of asthma death across Europe, and that's despite well-evidenced and well-established clinical guidelines.
Asthma patients can be difficult to manage, and sometimes patients with the greatest needs can be the ones who are the most difficult to reach and to engage in their care. It's important, therefore, that we all know exactly what to do when a patient presents, whether we are a receptionist, a nurse, a doctor.
In 2002, 2 patients in my practice died from acute attacks of asthma. Both were middle-aged men with young families, and the impact on everyone involved was catastrophic. At the same time, a local confidential inquiry into asthma deaths was producing data showing some common characteristics amongst people dying from asthma, such as failure to attend routine appointments, poor adherence with medication, and denial of the potential severity of their condition. Guidelines suggested that risk registers might be helpful, so we created our own at-risk list using the criteria reported in the confidential inquiries and applied an electronic flag to these patients' records. The aims were to facilitate prompt access for these patients so we could easily intercede as early as possible in exacerbations, and also to facilitate opportunistic asthma management when the patients contacted or came to the surgery for other reasons. It also highlighted to clinicians that these were people in whom, for various reasons, there were significant barriers to effective asthma management.
Based on the pilot work just described, we conducted a randomised controlled trial in primary care to evaluate at-risk registers and their implementation. The registers were made up of the 5 to 10% of people with asthma most at risk of an exacerbation, and this amounted to nearly 1,000 individuals throughout Norfolk. Our findings show this approach halved their hospitalisation rates and reduced A&E attendances and out-of-hours calls. Prescribing improved for both exacerbations and routine management. Overall, the intervention was well received by practice staff and reduced healthcare costs. We're hoping that this training programme will provide a stimulus for you to reflect on the management of asthma in your practice. However, we're not just concerned about how individual practice staff can intervene, but also about how the practice as a whole might recognise and engage with at-risk individuals so that whenever they present in primary care, they are offered intervention early and opportunistic management to reduce hospitalisations and death.
In this section, we'd like you to watch a case scenario based on real events, designed to illustrate some problems commonly encountered by asthma patients and clinicians, which are often associated with poor outcomes. Let's meet Danny and his family. Danny is 43 years old, divorced, unemployed and a smoker. He lives with his teenage daughter Abby and his new partner Jill, who is the main breadwinner. Danny's asthma control is poor. He tends to miss his regular asthma checks, does not monitor his condition and does not take his medication as prescribed. Please watch the following video carefully, as there will be some questions afterwards.
Morning.
Morning. How's it going so far?
Yeah, fine, thanks. But Danny Smith didn't turn up again.
Oh, I know who you mean. That's funny, he was in just the other week for his bad back.
Typical.
Shall I try and reschedule him for another appointment?
No, it's not worth it. He's already missed 3 in a row. Hopefully that means he's fine for the moment. Besides, we need those appointments for people who will turn up.
I see, and there's nothing I can... Right, yeah. Nah, but what if I... Yeah. Yeah. Yeah, well, yeah, thanks anyway.
Hey Dad, everything okay?
Yeah, it's fine. It's just another interview didn't go my way. Had to stay in all morning for the call and it turned out to be another rejection.
Oh, I'm sorry to hear that, Dad. I'm just popping the shops with Lisa. Do you want anything?
No, thanks, I'm fine.
Great, see you later.
Actually, did you get my blue puffy yesterday?
Oh no, sorry, I was meant to tell you. I tried, but they wouldn't give it to me because your prescription's run out. I texted Jill, didn't she tell you?
Nah, but it's fine.
Okay.
No worries.
Are you sure? See you later.
Yeah, see you later.
Hi.
Hi.
How was your day?
Oh, same as always.
What's wrong?
It's just my asthma playing up, is all. Oh, it's been like this all day. I've opened a window. It'll soon be fine. Although my inhaler's running low. Did you manage to get my repeat prescription sorted out yesterday?
No. I didn't know you were running low.
But Abby texted you.
Well, she didn't. Made me like a sieve, that girl. Typical.
Well, don't do that.
Do what?
That. Putting her down.
She's not even here. She's gone out again, doing a pretty good job of putting herself first.
It's not easy for her, any of this.
Well, it's not easy for me. I spend all day working to support the pair of you, and she still acts like I'm invading her life. Couldn't she have made the appointment while she was there? I have to do everything in this house.
It's not her fault.
Oh, so it's my fault.
I didn't mean that.
Danny, are you okay?
It's nothing. I've been like this before. Don't worry. I'll call the doctors tomorrow morning.
No. Let's try now.
Right, well, I'm off. Hope you have a good afternoon. Hasn't been too bad this morning.
All right then, have a good afternoon. Good afternoon, Hawthorne Street Surgery.
Oh, hi. Yes, it's my partner. His asthma's playing up a bit, and his blue inhaler's running a bit low. Would it be possible to come and get another one for him?
Okay, let me just take your partner's details. What's his name?
Danny Smith.
And his date of birth?
19th of April, 1972.
Okay, got him here. I can see his repeat prescription has expired. You'll need to see the doctor and get a new one. The earliest appointment I can give you is tomorrow at 3:30.
I'm on a long day at work tomorrow. Can't you do anything today?
No, I'm sorry. We're already overbooked this afternoon. Tomorrow's the soonest I can offer.
Okay then, let's go for that.
I've booked you in. Is there anything else I can help you with?
No thanks, that's it.
All right then, see you tomorrow.
Cheers, bye. Are you sure you'll be okay?
It isn't the first time. I'm fine, trust me.
Well, I worry.
I'm back.
Where have you been?
Oh, nice to see you too, Jill.
Don't talk to me like that. You were supposed to get your father his medicine yesterday. Now look at him.
Well, I tried, but the prescription was out of date.
And why didn't you book an appointment for him while you were there?
I'm not a secretary, Jill. I don't know when it's going to be free. I already went, even though I was busy.
Oh, and I'm not busy. Your father's not busy. You really are the most selfish
Will you
little...
quit trying to act like my mum?
Danny.
Dad? Dad, what's happening?
I'm calling an ambulance. Oh, my God.
Charlotte, I think you should see this. You were saying about Danny Smith not turning up. I just got this notification. He was admitted to hospital that afternoon for his asthma.
Oh, Alex, what are we going to do with patients like him?
You were at the end of this section. Of the 5.4 million people living with asthma in the UK, an average of 3 people die each day from the condition. Based on recent studies, as many as 90% of these deaths are thought to be avoidable. The National Review of Asthma Deaths was one such study. It took place between 2011 and 2014 to investigate the circumstances surrounding the deaths of people with asthma between those 3 years. This review describes a small but notable population of asthma patients who are at serious risk because of their asthma. There are many reasons why this may be the case. These include severe or brittle disease, suboptimal treatment of asthma or comorbidities, complex personal circumstances, poor adherence with medication or appointments, unawareness of the seriousness of their condition, or any combination of these. The NRAD findings highlighted some important commonalities between cases. For example, just under half of the people who died didn't contact emergency services or contacted them too late. More than half of those who died were not under specialist care. 3/4 of patients who died had not been given a personal asthma action plan. And avoidable factors, such as being exposed to smoke or smoking, or not taking their doctor's medical advice, were implicated in 2/3 of the deaths. It was also found that the patients who died were either overusing their reliever inhaler or underusing their inhaled corticosteroids. And a few were even on LABA monotherapies. Recently, the Asthma UK Patient Safety Failures in Asthma Care report indicated there is complacency about asthma management. While this report focused on the specific medications prescribed, it also noted that many patients were not instructed in proper inhaler technique. It is also accepted that opportunistic management can help improve patients' adherence to treatment and ability to manage their asthma day to day. Considering all this, it is clear that patient outcome could be improved. ARRISA UK aims to help practices identify asthma patients using their existing asthma register and provide practices with a system to facilitate patient-centred, flexible and opportunistic care. Now, we would like to introduce and discuss the At-Risk Asthma Register. As previously discussed, a small but notable proportion of people with asthma are at risk of suffering severe exacerbations, hospitalizations or worse. This can be prevented. A streamlined management system that helps identify these individuals, facilitates easier communication, offers opportunistic management as well as early treatment of exacerbations could greatly improve outcomes for these people. the ARRISA UK approach has been designed to provide such a system easily and economically. The ARRISA UK system can be considered in two parts. First, it qualifies patients as at risk based on specific criteria in the patient's electronic health record. Second, after identifying patients, a flag on the patient's record alerts practice staff to the at-risk status of the patients. So how is the at-risk register compiled? Well, for the purpose of ARRISA, routine primary care data were used to derive a patient identification algorithm based on the various factors associated with at-risk asthma. Practice software searches were developed based on these predictors to allow practices to compile their at-risk register effortlessly. The at-risk status of asthma patients is then flagged in the alert message section of the practice computer system each time the patient's records are accessed. Practices will be able to customize the message on the flag and, in doing so, prompt pre-agreed actions to aid patient management. This will be discussed in more detail in Module 2. Our earlier work suggested that an asthma risk register could help. Now, the 2014 British Thoracic Society and Scottish Intercollegiate Guidelines for Asthma state that a register of patients at risk may help primary healthcare professionals to identify patients who are more likely to die from their asthma. The use of such a register in the ARRISA study suggested that it contributed to an improvement in the management of exacerbations and a reduction in hospitalizations, which is why we believe that this system could be beneficial to practices. However, this larger trial will allow us to more definitively measure the impact and provide the necessary evidence to show whether at-risk asthma registers are effective across a wide range of practices. We're now going to replay Danny's story. This time, Danny has already been identified as an at-risk patient, and his records carry a flag to this effect.
Right, well, I'm off. Hope you have a good afternoon. Hasn't been too bad this morning.
All right then, have a good afternoon. Good afternoon, Hawthorne Street Surgery.
Oh, hi. Yes, it's my partner. His asthma's playing up a bit, and his blue inhaler's running a bit low. Would it be possible to come and get another one for him?
Okay, let me just take your partner's details. What's his name?
Danny Smith.
And his date of birth?
19th of April, 1972.
Okay, got him here. I just need to confirm with one of the doctors and nurses. Please hold the line.
Hello.
Hi Charlotte, it's Christy. I have an at-risk asthma patient on the phone who's asking for a blue inhaler because his current prescription has expired. What do I do?
If he's been using his salbutamol that much, I'd better see him this afternoon. Tell him to come in and book him as an extra.
Oh, okay, brilliant, thanks. Hi again. I'm afraid Danny will need an appointment before we can refill his prescription, but we can see him this afternoon. Does half an hour from now suit you?
Oh, thank you. We'll be there.
Right, that's just about do it. You can take the mask off now. How are you feeling?
Oh, much better, thanks.
The nebulizer's clearly worked, but we need to look at all your treatments. Here's a prescription for a course of steroid tablets, which will stop the attack. They take a few hours to start working, so we need to make sure you've got enough of your brown or blue inhalers for this evening and overnight.
Thank you so much.
My pleasure. Will you come back and see me tomorrow so we can see how you are? We also need to look at all your treatments and how we can prevent this from happening again.
You were at the end of this section. In this second scenario, Danny's outcome was drastically improved because his at-risk status was flagged and the practice team worked with him to schedule a flexible appointment. The ARRISA UK strategy is designed to be flexible and easily tailored by practices to match their existing procedures. The aim of the register is to flag at-risk patients and help practice staff work as a team to provide timely and opportunistic management to improve these patients' outcomes. It is essential to recognise that all staff members can make a difference to patient management at each point of contact. Successful implementation of an at-risk register requires the communication and cooperation of members of a practice, so that each member is able, for example, to offer opportunistic treatment to at-risk patients, to appropriately communicate with and engage at-risk patients, and to cooperate with colleagues to schedule flexible and urgent appointments when needed. We are now going to explore how, as a receptionist, you can get the most out of your at-risk register. Remember in Danny's case how useful the flag was for both the receptionist and the nurse. After seeing the flag, the receptionist was empowered to offer any appropriate help, including booking an emergency appointment. This worked well because everybody knew what action to take, and there was an agreed strategy in place that enabled everyone to work towards the same goals. There are many ways in which appointment booking and triage can be done in practices. However, the use of the at-risk register and associated flag provides support to the receptionists or any first point of contact with these patients to increase and facilitate access to appropriate care as agreed at practice level. It also helps staff to arrange chronic disease management follow-ups, such as follow-up appointments. By not having to rely on memory or knowledge about patients and their circumstances when communicating with either patients or colleagues, and to manage handovers. Often, communication with patients like Danny and his family can be a challenge. They often make contact when in crisis and will ask for or seek some form of rapid response from the practice while very stressed and anxious, so may not give clear and concise information on what's happening. This can come over as rude and demanding. This type of aggression can be very difficult to deal with, but knowing that the patient is on the at-risk register by seeing the flag helps to keep focus on the problem in hand and diffuse difficult situations. For example, using pre-agreed management options such as booking patients as extras. You are at the end of this section. Next step. In summary, the ARRISA system provides a way for practices to identify at-risk patients and facilitates the organisation of care for these patients. In the previous ARRISA study, it was shown that flags were useful and did not increase workload for the vast majority of the receptionists. While it initially takes some time to build a positive relationship with these patients, this will often set them on the right track, enabling them to improve their self-management and outcomes. And as Jenny, the asthma nurse from the original pilot practice says, the biggest reward is when they start coming to booked appointments, and they do. You have nearly completed this first module, but before we finish, we would like to discuss what will happen in the next module and how to prepare for it. Module 2 is designed to help you implement the ARRISA system in your practice, providing answers to practical questions you may have. It is ideally to be completed as a group or by at least one member of your team. It would be very helpful if you could discuss your ideas within your team before the training session and, if possible, to join for that module. Discussions could include suggestions on how to phrase the message on the flag, suggestions about the actions that different team members will take on seeing the flag pop up, and What would be the preferred method to agree and disseminate this information to the practice? So, if you can think of something helpful now, take the time to note it down.
Thank you for working through this module. We have explored the challenges of looking after people with at-risk asthma and provided an opportunity to reflect on some tools to make this process easier. Too many patients like Danny are admitted to hospital and we can do something about it. We look forward to meeting you at the next module to discuss how to make this work for you and your practice.